Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. What I'm going to be sharing with you today is a very nice example of follicular thyroid carcinoma. The case is courtesy of Dr. Anwar Al-Masri. So this is a case of a 54-year-old female patient who was noticed to have left thyroid nodule which was excised. And this is the very low power magnification, actually the scanning power magnification. And I'm going to focus on this area first and then the second focus here. And this is the first area that we're going to discuss. And as you can see, we have here a growth of the thyroid gland, mostly formed of microfollicles. And this growth is surrounded by a thick capsule, extremely important. This is a buzzword. Thick capsule, but as you can see here, there is a breach of this thick capsule. Now, on the higher power magnification, we have the thick capsule here, and we have the thick capsule on the other side with calcification, and then we have penetration of the capsule by the same follicular epithelial cells with the same arrangement as the cells within the nodule. And this is higher power magnification, exactly the same cellular component that is present throughout the capsule, outside the capsule, similar to what is present inside the capsule. And this is really what defines capsular invasion. Now, one question that might come here is that we're usually used to see or read about mushroom type of capsular invasion in order to qualify as capsular invasion in thyroid tumors for thyroid carcinoma. But remember this very important and elegant and extremely useful diagram of the instances where we have capsular invasion in thyroid follicular tumors or thyroid follicular carcinoma. Number one, we have to have a thick capsule, as is the case in our shared example that I just shared with you. And this is the typical, what we usually study, that we have to see mushrooming of the tumor, the same tumor that is forming the bulk of the tumor within the nodule, mushrooming into outside the capsular component that surrounds the nodule. But this is not the only scenario, because similar to our case, this protrusion or penetration of the capsule can have this pointy appearance rather than the mushroom-shaped appearance. And in certain occasions, a pseudo-fibrous capsule might form at the advancing edge of the penetrating component of the follicular tumor. What we do, then we draw an imaginary line between the two ends, the outer ends of the capsule. And then if we see that whatever component we have, as well as part of the pseudo-fibrous capsule, extend beyond the true fibrous capsule, this also qualifies as capsular invasion. So besides the mushroom-shaped invasion, we can have this finger-like projection, sometimes accompanied by a fibrous pseudocapsule invasion. And in 3 instances, these would qualify as capsular invasion. Now, into the second area that is highlighted here, and this was actually present outside even the area of the capsular invasion. And on higher power magnification, this is a large vein outside the capsule in which we have a large tumor thrombus focally attached to the wall of the large vein. This is on higher power magnification, just to confirm that we have the same cellular appearance of the follicular epithelial cells. Remember that these lack completely any nuclear features of papillary thyroid carcinoma, and then these are all sitting within the wall of within the lumen of the large vein, and this is the wall of the large vein. And this is another focus where we have the wall of the vein, then we have the tumor thrombus attached to one side to the wall of the vein, but also importantly covered here by the endothelium. An important small tip or a trick that we should pay attention to, and this is further another focus, all within the same large vein that I just showed you. And in addition to the previously mentioned attachment to the wall, as well as some endothelial lining to the thrombus. We see here red blood cells, just confirming or supporting that this is a vein. Now, in case that you were in doubt or you wanted to further support your finding with more objective evidence, we do CD31, and as you can see here, beautifully highlighting, decorating the endothelium of the large vein, but also the wall of the thrombus. This is a higher power magnification. This is the wall of the vein, and this is the tumor thrombus highlighted by the CD31 positive endothelial cells, another focus here, and this would really support the diagnosis of angioinvasive follicular carcinoma, in addition to the presence of the capsular invasion. And a fourth focus here, these are all actually taken from the same large vein that I just shared with you. So the final diagnosis in this case is follicular thyroid carcinoma with capsular invasion and limited vascular invasion. Now remember, one important clue from the low power magnification to start thinking about follicular thyroid carcinoma is the presence of a thick capsule and the presence of a very usually microfollicular, very homogeneous type or monotonous type of a proliferation of follicular epithelial cells lacking papillary nuclear features. Remember that capsular invasion does not have to be mushroom. Sometimes it can be finger-like a projection, but it has to penetrate throughout the whole thickness of the thick fibrous capsules. Occasionally, you can see the formation of a new pseudofibrous capsule at the advancing edge. This does not negate the diagnosis. You have to remember the diagram that I just shared with you and the imaginary line that you can draw at the outer aspect of the fibrous capsule. And if the nodule penetrates beyond the outer aspect of the fibrous capsule, this is also supportive that there is capsular invasion. Remember that with vascular invasion, you have to see large vein invasion outside the capsule. You have to have the thrombus that is attached to one side of the wall, usually lined by endothelium, and frequently the thrombus might contain fibrin as well. If you want to support your diagnosis, you can do immunostain, in particular CD31, which would highlight the vascular outline as well as the endothelial capping over the thrombus. And the reason why I use the word limited vascular invasion here, because if we have 3 veins or less involved by vascular invasion, this is considered to be limited, as the example that I just shared with you. 4 or more vascular invasion would mean that we have wide invasion or massive invasion by for the vascular spaces, and this would really impartial poorer prognosis to the case. I hope you find this tip useful in your daily practice. Thank you.